Welcome to the last of the webinars run by the college on the HSG protocols. Today we have an interesting session, and the Q&A at the end of this session will actually be an open Q&A for any questions pertaining to the previous webinars. I will also clarify one or two or three points that were brought up during the feedback that we received. But first of all, to start off today, we will be having introduction to the GPFIRST by Professor Mohan Thiru, right, from Woodlands Health, then followed by an experience on the use of GPFIRST by Professor Tan Zeli, our president of CFPS, and then we will go into the Q&A as a final part of the session, which is the last one in the series. So I think we can start even as we admit more participants in. So let me introduce Professor Mohan Thiru. Professor Thiru, would you like to start off?
Yeah, thanks, Raj.
Yeah.
So I think introducing GPFIRST is a bit of a misnomer because many of you actually know GPFIRST already. Just give me a second. I'll just start to share my screen. Okay, are you all seeing my screen?
Yeah, it's fine.
Yeah, okay, good. Yeah, so many of you, especially those of you from the eastern side of Singapore, would have known about GPFIRST in my previous life as Chief of ED at Changi General Hospital. That's where we started this. And many of you came on board. And since then, I've moved across to the northern side, to Woodlands Health. And we've started it up there as well, with together with some of our other sister hospitals, Kutek Puat, Tan Tock Seng. It's now moving across to involve the other clusters and other hospitals as well. So I'm just going to revisit some of the points on GPFIRST for those of you who are new to it. Bear with me if you have already part and parcel on board, and we can answer some questions as we go along. So, as you know, the growth in emergency departments, many of you will have seen the pictures in newspapers and heard about some of the issues that we're having of hospital overcrowding in many of the emergency departments, especially with the bed situation, and EDs being the last line of defense have taken a big brunt of much of the overcrowding issues. And we actually saw this some years ago in Changi General, and we actually had to do something to sort of mitigate the growth of the non-urgent, mild to moderate conditions, patients that come to ED for these conditions, which actually can be treated by our primary care colleagues and GPs. In fact, many of you in the north and in the east have actually been treating much more acute conditions and over the years as part of the growth of GPFIRST. And one of the things that that we go about is to have a public campaign to get patients to seek care at a GP or primary care before actually going to the emergency department for non-urgent, mild to moderate conditions. And as part of Healthier SG, this is one of the key niche programs that will be consolidated into the Healthier SG program as well. So what's in it for these patients? When they see the GPs, and the GP then decides to refer these patients to either the urgent care or the emergency department, they will actually get a $50 rebate on the ED fees. So the ED fees are $120. They will only pay $70. They will also be seen as a priority over the other cases in the emergency department. Of course, not as those coming in with ambulances, but they will be given priority over the other cases in the P3 area of the emergency department. It was started first in Changi General in 2014, and it actually helped to reduce the CAGR growth of P3 attendances from 8 to 9% down to about 4 to 5%. So there's still a growth, but actually we've had to suppress that a little bit. What's interesting is over the years, especially after COVID saw a decrease in ED attendances, especially the P3 attendances. But after COVID, the numbers have started to go up again. But those hospitals that have had GP First has actually had a smaller growth. And interestingly, in Khoo Teck Puat, where we have an urgent care plus GP First, it has actually been stagnant, the P3 growth in the ED. So actually, it's helping Khoo Teck Puat substantially, because Khoo Teck Puat is one of the worst hospitals that have been hit by hospital overcrowding, long bed wait times, etc. So what are the benefits? Just remember that most patients over the years prior to the initiation of GP First come to think of A&E not as accident emergency, but actually they actually think of it as anything and everything, you know. So they come there for minor ailments, for extension of MCs, for minor sprains, and actually clog up the workflows and the whole, not only the workflows in the emergency department, but because they end up doing unnecessary tests and labs and RATs investigations, they clog up some of the other infrastructure services in the hospital as well. So remember, a URTI seen by a GP in the clinic is quickly given, examined, you know, and then given medicine and discharged very quickly. But if that same URTI patient came to the ED, I can almost guarantee you that that patient will receive a chest X-ray, a full blood count, a renal panel, and a CRP maybe. And nowadays, they also probably throw in a COVID antigen testing as well. So you can see, because of the pretest probability of certain conditions in the ED, there's less of a risk appetite in terms of patient management in ED. So whole host of unnecessary lab tests. They end up waiting up to some EDs. You can wait up to 6 to 7 hours in the P3 area before you can get to see a doctor. And of course, the charges are much, much more expensive in A&E and rising all the time. And there's going to be another round of fee revisions in the coming year as well for EDs. So again, it's more out-of-pocket expenses for patients. As mentioned before, there is a big subsidy of $50 to offset the GP attendance fee so that the patient does not get a double whammy, and they're also seen as priority over the cases. So what happens is that in the referral pathway, the patient arrives at your clinic, you need to do a triage for these patients, okay? If patients do not need emergency care, they should be fully managed at your clinic. Those patients that require further care at the ED, right? If it's a medical emergency, right? Say you suspect a life-threatening or time-dependent condition like myocardial infarction, stroke, anything that needs to be speedily treated, call 995, okay? Do not call private ambulance. Do not tell patient to take their own transport to hospital. Call 995, right? Because once the patient gets onto the ambulance actually activates the hospital to stand by the PCI lab or the PCI for thrombolysis or for EVT for strokes. So we try to cut down the door to treatment time for these conditions. If the patient is not a life-threatening, limb-threatening condition, okay, you can then take your time, inform them of the terms and conditions of GP First, get to do all the paperwork, which includes filling up a referral form. This form is important. The patient can then either self-convey or the next of kin conveys them to either the urgent care or emergency department. So in the north, you have a choice between urgent care or the emergency departments. And those of you in the north would have been told what are the criteria for urgent care and what's the criteria for ED in our communications with you up in the north. There will be more urgent cares being set up in other hospitals. And I think by the criteria for referral to urgent care will probably remain the same. I'll come to some of these terms and conditions in a short while. So there are a small group of patients which are excluded. These are the children who are referred to A&E, the emergency department in KKH, because they are not part of the GP First program. As part of the GP First, we actually give all our GP colleagues sort of a report card on how their referral patterns are regularly. It could be 6 months, it could be quarterly, it could be a year, depending on which hospital you are referring to. But we have what is called an appropriateness algorithm, whether these cases are appropriately referred to a GP. It's not punitive, it's just purely for feedback and self-learning. So if there's any procedure or test done in the ED, okay, that's considered appropriate. However, if the patient goes to the ED and is dispositioned of without any lab test or procedure or admission, or they could be they then just referred back to a GP OPD or given an SOC appointment, that's considered inappropriate, because we do not want patients using ED as a shortcut to faster SOC appointment times. Okay, so that's one of the terms and conditions. So a few FAQs on GP First. Can GPs refer patients to EDs or UCCs they're not partnered with? If the patients prefer, yes, they can. Previously, you couldn't. You have to refer it only to your partnering hospital, but we've taken that away because we do realize that some patients work in Choa Chu Kang but live in Changi, so they might want to go to an ED which is closer to their home. Can patients use the referral form at a different ED? So same thing, yes. Anyway, we've now unified. We have a unified GP First form, which is generic to all EDs. What happens if the patient is not given a hard copy of the GP First referral form or forgets to bring the GP First referral form? Then sorry, they won't get the discount, okay? Because we don't want patients gaming the system and saying that they are part of GP First referral, and then try and get the $50 back and get to see the doctors faster. So no gaming, okay? So no form, no subsidy, no fast treatment, no fast tracking. What happens if GP First form is incomplete? That means you don't put your MCR number, you don't put in some of the details required in the GP First form. Then, of course, we'll honor it. Of course, patient comes first, we'll honor it. But next day, one of the administrators may call you for some details to fill up and then do some rework. So try to fill up the forms completely. It's quite simple. It takes you not more than 2-3 minutes to fill it up, right? Will referring GPs receive follow-up information on the patients they have referred? Previously in Changi, I used to mandate that every GP gets a reply letter within 24-48 hours after they're seen by the ED. But because now we're in the phase of PDPA and security, we had to stop that. So the only way you can get the information is to access it from any HR on what actually happened to the patient and what was actually done for the patient. Okay, so these are the contact numbers. You might want to take out your phone, take a screenshot, but we'll share the slides with you all later on. It's recorded, so you can get the numbers. Each of your hospitals should comms with you all on their contact. Okay, so you don't have to contact everybody, just the one that you're partnered with. I'm just going to quickly go through some of the cases that clinical decision rules that we use, okay? So many of these rules are available. They will be available to you as part of a series, a collection of information articles, which we rolled out as part of GP First. But these are some of the conditions that are not considered emergency cases in the current day and age, okay? So simple lacerations that can actually use Therastrip to close, right? Simple bruising, abrasions, with no suspicion of fractures beneath the abrasions, right? Closed fractures of the phalanges of the lower limbs, because we won't do any casting or splinting of these patients, right? Small burns that can be actually simple dressing. And then, of course, some of the clinical decision rules that we use, which I'll show you in a short while, that we will not do any further investigations in the emergency department as well. Also, exacerbations of some chronic conditions that do not require admission. I put the word here, asymptomatic, uncontrolled hypertension, okay? So nowadays, we actually don't treat the patients with asymptomatic, uncontrolled hypertension. If they have underlying other medical conditions, we might give them an SOC appointment. If it's difficult to control, we give them an SOC appointment. But if it's just because they stopped taking their medicine or for some other reason haven't started taking their medicine, we may start an antihypertensive medication and refer them to the primary care again. We actually will not do further investigation for these patients. So again, asymptomatic, uncomplicated, poorly controlled DM, blood sugars less than 20. We actually also avoid unnecessary treatment, giving insulin in the ED and bring it down and discharging. We do not do that, okay? We just advise the patients appropriately and discharge the patients. So there are other conditions, as long as there's no red flags, and I've included this as part of a series of instruction material for you all as part of a package, which all the hospitals will have access to, and you all will have access to it as well, right? Dengue, again, also, sometimes they are referred to the hospital, but again, no red flags again. So we actually discharge a patient with follow-up by repeating the platelets or renal panel again in a few days' time, right? So I just give you all a case now, okay? Just focus on this case. So say if you're like me, I'm not 40 years old, I'm a little bit older than that, and I've got non-exertional poking chest pain, and I'm very worried that it's an AMI, right? It is not reproducible on palpation, and I've got no other CVS risk factors, right? So you've done an ECG, ECG looks normal on this patient. What do you do? So you can take a picture of this, because what we actually use is this tool, which is available on the internet called MD Calc. And there are actually clinical decision rules for a variety of symptoms. And for simplicity, I've actually included this in the handouts that the GPFIRST facilitators will give out as well. So for example, for this patient with chest pain, I would plug in all the values, right? So there's a no for being of the age group, right? No known cardiovascular risk factors, pain not worse on exercise, pain is reproducible on palpation, right? And I assume that pain is cardiac. Okay, so that I put in all the points here and I come up with a score. And this score then tells you whether the patient is low, medium, or high risk, right? So if the patient is low risk, you tell the patient that you are low risk for AMI, you now have a choice, okay? If you go to ED, Dr. Mohan is going to make you wait 6 hours there for lab tests and all those things, and you'll be treated as an outpatient, okay? So what we can do is we can refer you to a SOC, especially many hospitals now has fast-track SOCs for chest pain, where they get evaluated by a cardiologist. They may get a treadmill test or a 2D echo or a cardiac CT and dispose of, right? So they've been treated as outpatient. So it's outpatient or referral. If it's high risk, they go to emergency department. So this calculator actually tells you whether the patient is low, medium, or high risk. But I just put in a caveat here. As with all clinical decision rules, no matter what clinical decision rule you whether, okay, you must use common sense. If you see any indication that sometimes the patient may have all negatives on the history and physical examination on the calculator, but if you see an ECG, we say a suspicious ECG, ST elevation, ST depression, all that goes down the drain. You refer the patient straight away. So what I'm saying is that your clinical acumen is the best clinical calculator, okay? And with your experience on the ground, you know, especially whether or not a patient is sick or not. So use your clinical common sense, rely on that more than anything else. With MI, you know, things are changing all the time. They're now called STEMI equivalents, which are also PCI-able lesions. And these patients are also taken to the cardiac cath labs, and which you should call the 995. So learn to recognize this. Take a picture of this QR code, because it's something new that came up this year. How to recognize STMI equivalents. That means patients that also require PCI and require 995 or conveyances to the ED. Okay, so take a picture and then the reference articles. This is just for chest pain, but there's a whole, this example of some of the clinical decision rules we use. I'm just citing chest pain because that's one of the commonest reasons that we see referrals for, right? So I just want to end off by highlighting a few things. The validity of GPFIRST referral is only valid on the day of issue, but of course, the patient sees you, your clinic is open to 11 p.m. at night, we will honor it till the next morning. Okay, so sometimes, in fact, it goes beyond 2 a.m. the next day. Although it says at 2 a.m., we actually more honor it. If it comes in, if the patient comes at 8 a.m., we still will honor it. But tell the patient they should go straight to the ED and not go home, sleep, and then come there the next morning. Patients need to bring their IC, work permit, passport, right? The completed hard copy form, right? It should be serialized because we have patients who actually modify and cheat the system by actually doing their own printing on paper, the form to get a $50 rebate. So we see all these things happening, right? Or it can be printed out to the CMS system as well, right? Make sure that the forms are completed. Like what I said, or else you get a phone call the next day, end up reworking. Now, specialized investigations, referral for specialized investigations. Sometimes I see patients that are referred for CT scan. Okay, that's additional fee. Okay, it's not part of the underlying A&E $120, $150. Those are extra fees payable. So do not promise them that 120 covers for everything. That's something which is common misinterpretation. We will try as far as possible to send out CME materials to you. Either we do it by using podcasts, by articles, and we send it out usually once every month or every 2 months or so, and it's curated by myself and a team from MOH as well. All right. Let's see now. Okay. So yeah, so we'll be doing the appropriateness criteria and giving you all a report card, non-punitive at all. Okay, we've never made it a name. It's just private to you, and so that it's purely for learning purposes. Okay, with that, I think I can stop.
Oh, thanks very much, Prof. Mohan, for that really very good explanation of GPFIRST. As someone who uses GPFIRST from quite early on in the West, I found it to be very, very useful actually. And although there are questions that I've seen that where they say why do we reward patients with a $50 discount? Actually, it's not really a reward. It's almost like a nudge, so that if they have doubts about going because they worry about cost, and to them A&E is not cheap, A&E is expensive. So when they realize that actually they don't have to double pay and they have some help and to be able to mitigate some of the costs going to the A&E, more often than not they're happy to go. And I think at the beginning when we saw GPFIRST, certainly in Choa Chu Kang, and certainly from my practice, I mean, we don't use it an awful lot, but where we have had to use it, it's been very good. But subsequently, we actually had the Peds Engage, which is the pediatrics part of GPFIRST. And actually, when that came along, I really welcomed it because is really something very good, because it certainly helped our patients. And we do have pediatric urgent care center in Bukit Panjang, and that's been also a great help. But I do have to just share with everybody that it's important that when you do Peds Engage, right? They actually run a very nice course, which has been organized by I think it's Sing Health Academy through KKH, and it's actually been a great learning experience. And there is an MCQ to take at the end, so please read the answers, because each question that comes out actually has an answer, and that answer actually is very educational. So yeah, so I think this is a great initiative, and I think it'll be very popular as it gets rolled out more and more throughout Singapore. Yeah.
Yeah. So if you refer the kid, just to maybe clarify, so you refer the PEDS patient to and outside KKH, we will still honor the GPFIRST subsidy. But if the patient gets referred to KKH, there's no $50 rebate there,
Yeah.
basically. Yeah.
Yeah. So for in our case, we because I'm in the West, so
Yeah.
they go to
NUH.
NUH and it's fine. Yeah.
Yeah. Peats are different species altogether.
Oh,
so-
they're a different animal altogether. Oh, it's so scary.
yeah. Yeah.
Just want to mention,